trial with the primary objective to compare hemodiafiltration when delivered consistently in this high dose. So that is the most important difference between CONVINCE and the other European trial, when the consistently high dose was delivered, and then the effects on all-cause mortality. And the second difference with the earlier 4 European trials is that we assessed as a secondary objective patient-reported outcomes to analyze patient perspectives and compare these effects between treatments. And indeed, as was just mentioned, this trial was exclusively funded, I have to say, by the European Commission. So we published that in the New England Journal, and probably you have seen this slide multiple times, and we found that with respect on the effect on all-cause mortality, the patients on hemodiafiltration had a 23% lower risk of all-cause mortality. And actually, I think it's important to realize that that's quite a big effect, 23% reduction. So an often heard criticism on data like this is, of course, that, these are trial patients, so highly selected patients. What about so-called real-world evidence? And I can say that there are now multiple real-world data sets, and this is just one example published more than a year ago, representing a huge group of patients, 85,000 persons, in which it was found that those on hemodiafiltration had a 22% lower risk of all-cause mortality. And when indeed this was further analyzed, this effect appeared even bigger. And I can tell you this is one of the largest so-called real-world data sets. There are now multiple similar data sets, which basically all or most of them point in the same direction, that is superiority for hemodiafiltration. So, as I mentioned, the most important secondary objective was to assess patient-reported outcome. And for that, we used the so-called PROMIS tool, Patient-Reported Outcome Measurement Information System. And this is a tool developed in the Harvard University and represent a self-reported measure, or the assessment of self-reported measures for functions, symptoms, behaviors, and feelings related to 3 big components: physical, mental, and social health. And you see here in somewhat detail what aspects within these domains, what aspects are addressed with this tool. And this slide shows you the results of these patient-reported outcomes when analyzed as one group. So in this slide, I do not show you the difference between the 2 groups, but results were analyzed as one population. And then you see, when compared to baseline, various aspects: the physical composite, mental composite, physical function, fatigue, pain, sleep, anxiety, cognition, depression, social participation. Basically, they all deteriorated over time. On the horizontal axis, you see time. So a deterioration of these aspects, and for instance, here an increase in the level of fatigue, an increase in the level of pain, and an increase in the level of sleep disturbances. So when we take a look at the 2 arms, so the 2 different therapies, the results look like this. And I can tell you that in all aspects, hemodiafiltration performed better than standard hemodialysis. And that was statistically significant in 3 domains, and that is cognitive function, physical function, and social participation. So, for instance, the cognitive function, you see the blue line, hemodiafiltration, appears to be, shows a slower decline and even a sort of leveling off, which does not occur in the patients on hemodialysis. So this is actually, I think, quite exciting information, and I will address that further in my presentation in a little bit more detail. So one of the shortcomings of a trial is usually that it's not big enough to find out whether there are any differences in cause-specific mortality, whether there are any patient groups which especially benefit. So we did this meta-analysis, again, when adding the CONVINCE data to the data set we already had of the 4 earlier European trials. And we published this analysis in the Lancet a little bit more than a year ago. So this table is very similar in structure as I've shown you in one of the earlier slides. So all-cause mortality, again, these 3 tertiles of delivered volume. And of course, the CONVINCE data were especially represented in the high group as for the protocol, as I mentioned earlier. So again, you see a rather big effect with respect to all-cause mortality, a big effect on cardiovascular, and now also, and that's the reason why I show you this slide, or one of the reasons I show you this slide, is an effect in infection-related mortality, a quite substantial effect. And whether COVID was included or excluded, actually, it doesn't make any difference. So this analysis suggests that patients on hemodiafiltration experience a lower level, and actually a quite considerable lower level of infection-related mortality as compared to standard hemodialysis. And we think this is quite an exciting sort of information. So this presentation in tertile is basically rather artificial. So when you take out all the patients on hemodiafiltration in the previous in this analysis, in the Lancet analysis, we had about 2,200 patients on hemodiafiltration. If you take these out and analyze these as a group, then the dose response curve of the relation between convection volume and all-cause mortality looks like this. So a rather gradual relation where the confidence interval is especially low, of course, in the range of volume of which we have the most data. But the slide clearly suggests a more is better relation with respect to convection volume and outcome. And this is shown in this Lancet publication. So some further aspects actually, so the CONVINCE data were presented now 3 years ago, but in the past 3 years, a lot of things actually happened, and I will briefly address some of these new thoughts, new developments. And the first is how to further refine prescription. So it's unlikely, and you probably agree with me as physician, as healthcare worker, that a one-size-fits-all strategy is in most cases not true. So it would be interesting to know what sort of patients especially benefit of hemodiafiltration. And we did an analysis, or we constructed a prediction model based on the 4 earlier European trials and published that a couple of years ago, and divided the population in strata of predicted median survival benefit when on online hemodiafiltration versus hemodialysis. So 4 strata, the predicted benefit less of 6 months, between 6 and 12 months, between 12 and 24 months, and greater than 24 months. And if you look here at the patient characteristics, then you see when going from left to right that the patients with the highest benefit here are especially the younger one, the patients less likely to have diabetes or less likely to have cardiovascular disease, have a higher creatinine level and a lower CRP. So overall, the better patients, the better hemodialysis patients seem to have the greatest benefit of being on hemodiafiltration. And when shown in a different way, please take a look at the left side, where the dark gray area is on any form of hemodiafiltration, and on the horizontal axis, the predicted median survival benefit in months. So you see quite a considerable distribution, and the light gray is when on high volume hemodiafiltration. So then the curve is shifted to the right. And these patients in the most right column of the previous slides obviously are especially here in the right area of the curve. One disadvantage of such an analysis is that, of course, in the data set, median follow-up was about 30 months, was artificially truncated because these were all trials. So the real absolute survival benefit is most likely much more than is indicated on this slide when follow-up would be indefinite. And that shortcoming is addressed on the right part when we measured or we calculated the predicted median survival in days per year. So on any form of hemodiafiltration, the median is almost 50 days, and on high volume, the median is about 75 days, so 2.5 months per year survival benefit, so quite considerable. So we have now updated this analysis with the CONVINCE data added, and did some further analyses, and that is now in consideration at a major journal. So the next topic I would like to address is patient-reported outcomes. And so this is actually a sort of model representing what actually happened. So we do a biochemical sort of intervention, so fast removal of uremic toxins, and we hope that this biochemical intervention has a beneficial effect on symptoms, and that this reduction of symptoms will result in improvement of all sorts of physical and mental functions, and that this result in a better general health perception, ultimately leading to an improvement of health-related quality of life. And if you really think about this, that we do an intervention here on the far left, and that should have effect on the far right, that's actually quite exciting that we see that happening. So this figure I showed you again, and I would like to show you again because it's actually quite special to find an effect on cognitive function. And of course, we know that when dialysis patients receive a kidney transplant, an improvement in cognitive function usually also happens. But this is actually the first time that in a trial setting, cognitive function improves when changing a kidney replacement therapy, a form of dialysis therapy. So I think this is really a very exciting sort of results. And we address that in much more detail in this perspective, which is recently published in CJSON, trying to focus more on this aspect of the results of CONVINCE. And I think it is actually nice to take into remembrance that in this study published already a couple of years ago in the pediatric field, aiming at all sorts of cardiovascular effects, it was mentioned, so in children, that children on hemodiafiltration performed better at school, which you might say is a similar sort of effect as we have shown in CONVINCE. So it's really exciting to know or to find that actually something happens in a sort of better preservation of cognitive function. And of course, we do not really know what the mechanism could be, but the improved hemodynamic stability during hemodiafiltration could play a role. The better removal of all sorts of toxins could play a role, of course. The overall reduction of the chronic inflammatory state could be of relevance. And overall, actually, we think this is really a topic which deserves further research to find out what actually is happening. And actually, is there any comment? So we think that this really should be more of a focus in everyday clinical practice. So this slide I've shown you before, and again, I would like to emphasize this effect on infection-related mortality. And actually, that was shown in this analysis again. So this is a real-world data set on hospitalization outcomes comparing hemodiafiltration versus standard hemodialysis. Again, very large population, so 32,000 patients on hemodialysis, almost 40,000 patients on hemodiafiltration, where it was found that patients on hemodiafiltration had a lower risk of hospital admission, about 22%, and the total number of hospital days was indeed lower as well. And the type of hospital admissions that was not only cardiovascular related and fluid related, but also infection related hospital admissions were lower during hemodiafiltration. So what we found in CONVINCE, that there is an effect on infection, is basically confirmed by analysis like this. One other aspect which I think is now getting attention is the environmental impact. And actually, this is an editorial published 1 week or so after the presentation of CONVINCE. And in this editorial, the question was asked, hey, does this 23-liter of convection volume means that indeed more water is necessary for hemodiafiltration as compared to standard hemodialysis? And I have to say that we have not addressed this question specifically in the CONVINCE trial, but indeed, of course, I very much agree that this is a really important question. And I would like to suggest you to start reading with this. this review by Bernard Cano and co-workers, where they did a detailed simulation analysis with quite a lot of real-world data. And the message is that basically, if you do that hemodiafiltration could be associated with not a higher water usage, but a lower water usage as compared to standard hemodialysis. And that has to do with a lower level of dialysate flow, which is necessary to perform hemodiafiltration as compared to hemodialysis. And this here, quite a considerable number of real-world data were presented, and that was actually confirmed here in 2 presentations during the ASN meeting in Houston 6 months ago. One study by Davita Centers in Brazil, and this was again a sort of estimations of water savings in the United States when starting hemodiafiltration. So this is really, I think, a topic which will get more attention in the future. And then, of course, the comparison with other sorts of therapies where convection is given. So we have low flux, which is not so often used anymore. So during high flux, the main mechanism is diffusion, and there is some convection, but these processes are uncontrollable, unmeasurable, and unpredictable. And this so-called HDX, or the super high flux or medium cutoff membranes, these membranes offer greater pores and some other specific features where diffusion could even be more effective and there's more convection, but still these processes are uncontrollable, unmeasurable, and unpredictable. Whereas in online hemodiafiltration, we have these 2 processes where the process that is related to outcome, and that's convection volume, is fully controllable, measurable, and predictable. So this is, I think, a still ongoing discussion what the place of these super high flux membranes could be in everyday clinical practice. So to summarize, online hemodiafiltration represents for the first time in decades an adjustment of the basic principles of hemodialysis that turns out to be clinically meaningful, and this is especially the case when high volume is offered. Superiority on clinical endpoints is shown by trial and real-world settings. And trial data show beneficial effects on domains of patient-reported outcomes. And I think a wide range of possible additional beneficial effects are now on the horizon, and one of these is that it is even more cost-effective, that is cheaper than hemodialysis. Please take into consideration that the lower level of hospital admissions really means a cost reduction. And it can be delivered over a prolonged period of time, and prediction and the prescription variables are basically pretty simple. So overall, I would like to conclude that hemodiafiltration should be considered to become the new standard for all or most patients because it performs better on key outcome variables. And because of this wide range of additional benefits that are on the horizon, I think it is fair to conclude that we are only at the beginning of the full understanding of all the benefits. And this is the last slide, which is added by Fresenius, obviously. So I stop sharing now, if that is okay.
Feel free to do so, yes. Thank you so much, Peter, for sharing your deep knowledge and this broad view on HDF and on the CONVINCE study data with us. And so we stopped the recording already, and we have enough time left for the discussion. So please type your questions into the Q&A. And let me have a look. So we have a first question already from Stefano Stewart. And his question is, if the post-dialysis body mass index value did not impact the survival rate in the longitudinal analysis, and he mentions the 4 categories with analyzed, and the convective volume was almost the same for all patients above 25 liters. Does it mean the convective volume should not be adjusted according to the body mass index?
Yeah, I think this is still an open question. So the average body weight in the European population is about 72 kilograms, and in that population, this analysis works. But how to dose, for instance, hemodiafiltration in patients with low body weights, such as in the Far East, or with much higher body weights, such as in the United States, I think we still need to do detailed analyses on that.
Stewart, and the UDL released its statement only on randomized prospective clinical studies without evaluating the real world data and very high quality level observational studies. And many of these prospective studies were very old, and their conclusions were based only on the HDF as a technique and not on the delivered convective volume. Don't you think it's a bias in the UDL?
Yeah, I absolutely, totally agree with Stefano on that. That is actually, I think, a major flaw of the UDL papers. I think it's, although from a methodological point of view, you might say, well, we in a certain analysis, I include all hemodiafiltration studies, but over time, I think the way we give hemodiafiltration has really developed, and it is not realistic anymore to take into consideration all these older studies. So that's one aspect, and I absolutely totally agree with him that leaving out the discussion in this consensus statement, the many very well conducted real world data sets, which basically almost all point in the same direction, is also, well, a flaw.
Yeah. Do you think they plan on an update soon?
Actually, I don't know.
Okay. We have more questions, and it's from Juliane Feuerle, and she asking whether you could comment on the results of the MOTHER trial on the medium cutoff dialysis. That was, well, the question is that was recently published. I would like to rephrase it a little bit. It has been presented at ERA. So, yeah.
Yeah. Yes, well, this is a very well expected question. Indeed, I attended the session in Glasgow as well, and I heard the results. And I think the only way to really comment on the MOTHER trial is the moment we see the full publication. And I think the fact that the full publication was not available at the time of the presentation of these results. It's now in many of these big presentations you see on the last slides. As of today, we have published the results of this and that trial in the New England or in JAMA or in Kidney, whatever. But they did not mention that on their last slide. So apparently they have trouble getting it published.
Okay.
So my suggestion is please wait until the full data set and the full publication is available.
I don't see more questions in the chat, but maybe one question from me. So the HDF studies, I think they mainly involved prevalent patients.
No.
And do you see HDF also as a first choice for incident patients?
Yeah, I don't see why it should not be considered as such.
Yeah.
I think there is now so much experience with hemodiafiltration that I cannot think of a reason why you should not start with hemodiafiltration in new patients.
Yeah. Let me have a last look whether there are questions. Yes. There is a question from Bernd Stegmeier, and it's what is the reason that the first 23 liters have no benefit and the added liters are so important? The sub-variables were not significant in the CONVINCE.
Yeah, that's a very important question.
Yeah.
And let me really emphasize where this number of 23 liter comes from. As I mentioned during the presentation, basically it's a very artificial number because it is the low end of the highest tertile in the first analysis we did of the 4 European trials published 10 years ago. So it's basically a rather artificial number, and that is precisely the reason why we did this Lancet analysis, looking in more detail what actually the relation is. And when I showed you this figure of this very gradual relation, it really shows more is better. So any volume below 23 liter is not bad, is not detrimental, is not harmful. It's simply less beneficial than a volume above 23 liter. So that is really very important to look or to appreciate the results as such, and not this 23 liter as a sort of absolute number where 22 is bad and 23.5 is good, because that's not the case. And also, I'm a physician. That's not the way it works in medicine, these absolute cutoffs. That's not the way it works. This Lancet graph, it simply makes sense. Higher results in more effect. That's in many medications also the case.
Yeah, there is already a second question from Peter Stegmeier. If I cannot achieve more than 23 liters, what should I tell the patient? Anything you would like to comment on that?
Well, first, stay on hemodiafiltration. That's number one. And number two, if you would like to try to achieve a higher volume, and there are multiple steps possible, has this to do with insufficient blood flow. So the blood flow could be increased. So maybe the needle size could be of relevance. A change in needle size. A somewhat longer treatment time if the treatment time is relatively short. So there are multiple steps, multiple variables that could be considered, aiming at achieving higher level of convection volume. But if all these actions are not possible or are not effective, but still this 23 liter is achieved, please, my suggestion would be stay on hemodiafiltration.
Mm-hmm.
And again, and again, if the dosage, convection volume, is 22 liter, that's not bad, that's not detrimental, that's not harmful. It is simply less effective, less beneficial. And that's also important to realize. That's that interpretation of the figure, the Lancet figure.
Yeah, thank you. We have more questions, Peter.
Yeah.
And another question from Stefano Stewart, and he's asking whether US patients who are potentially different compared to European patients, are they different in terms of high volume HDF outcomes?
Yeah. That's a good question. Well, he probably knows better than I do that now hemodiafiltration is massively implemented in the United States. Fortunately, I think, for the patients in the United States. So now I think there's an increasing amount of information becoming available on the effects in the United States. But I don't see any reason why beneficial effects which have been found in European populations, but also in populations in the Far East, in South America, so on multiple locations on the globe, why they should not be found in the United States as well. So that is my expectation, actually. So I hope such data will become available in the not so far future.
Mm-hmm. And there are more questions. One from Aidan Ho, and looking a little bit into the future, asking what will be the coming focus of the HDF-related studies to further investigate the pathway of the clinical benefits or other perspectives?
Yeah, that's an interesting question. As you may know, there's still one trial where we are waiting to find out what they found, and it's a British trial, H4RT. Actually, I was hoping that they would present the results in Glasgow, but nothing happens. And after H4RT, will there be more trials, hemodiafiltration trials? Well, actually, I doubt.
Yeah.
Maybe in specific populations like in China. But who is going to organize these trials and are going to fund these trials? So I really would like to emphasize that please produce real world data sets and try to find out in huge populations, and then we can address all sorts of detailed questions. But real formal trials, again, addressing the question whether hemodiafiltration is better than standard hemodialysis, I don't know. I don't think these will happen. And please consider, investigators have to submit such a question to ethics committees. And ethics committees could say, well, are we not convinced by now? Yeah, sorry that I used the word. So basically, the answer is actually I really don't think formal trials will be done anymore.
So Aidan Ho has a second question regarding the convection volume. And the target we are aiming should be 23 liters per session or 69 liters per week. Some patients are doing twice per week and some three times per week.
Yeah. Interesting question. Well, this 23 liter, but it's a very practical number. Of course, I do realize that in everyday clinical practice, it's something the nurse, the technician understands. So it's sort of practical to work with. And yes, in patients who are on a twice weekly schedule, they usually have considerable still urinary output, so still some residual kidney function. And probably the most practical thing is to aim at this 23 liter per session when on a twice weekly schedule. It's not realistic, I think, to have this 69 target in twice weekly twice weekly schedule when doing post-dilution. That's not realistic. That will not work.
So there are even more questions, Peter.
Yeah, please.
Yeah. What is your personal opinion about the reason why HDF in not official guidelines as standard of care is, probably it should read, is not in official guidelines as standard of care and superior method compared to HD?
Yet.
Yeah, yet, okay.
Yeah. No, of course, that's a very, very good question. And I've been in contact with KDIGO and yeah, whether they find it now the time appropriate to organize a consensus statement on that. And one aspect to that is, or one part of the answer to that is that basically they said, well, we know of one trial still we're waiting for the results of one trial, the British trial, as I mentioned. And most likely, as I mentioned earlier, there will be no trials done afterwards, after these results are available. So what I foresee is that KDIGO will organize a conference any time between now and 12 months or 18 months or so from now. And yeah, these processes in guidelines, of course, go pretty slow. So it's a very good question, but yeah, I know that KDIGO is considering the idea of, well, of concluding that the time is now appropriate to organize such a conference.
Thank you. So let me have a last look. I don't see more questions right now. So then I would like to thank you, Peter, for your great presentation and the audience for this good discussion we had. I wish you all a good rest of the day. Take care, and I'm looking forward to seeing you again in our next webinar in July.
Thank you very much.